Hi and welcome to a lecture on stroke. The following lecture will be discussed in two sessions, the first being a discussion on acute stroke and later the prevention of ischemic stroke. Stroke, also known as cerebrovascular accident, cerebrovascular insult or brain attack, occurs when poor blood flow to the brain results in cell death. Strokes are a medical emergency and urgent treatment is essential because the earlier the treatment, the less damage is likely to happen. It is important to note here that there is no acute phase intervention of proven value for hemorrhagic stroke. The post-acute treatment of hemorrhagic stroke is similar to that of ischemic stroke, except that antithrombotic drugs are avoided in hemorrhagic stroke. Now let's get to discuss pharmacologic choices. Ischemic stroke and thrombolytics. Thrombolytics such as alteplase should be administered intravenously as soon as possible following the onset of stroke in patients who meet strict eligibility criteria. Antiplatelet therapy. If intracranial hemorrhage is excluded by CT scan, but alteplase is not indicated, then aspirin 160 mg can be given immediately, and this should be followed with aspirin between 80 to 325 mg daily. Here again, when alteplase is used, it is important to wait until intracranial hemorrhage is excluded by CT scan 24 hours after treatment. For patients who were taking aspirin prior to their stroke, other antiplatelet agents such as clopidogrel 75 mg daily or a combination of aspirin with dipyridamole twice daily can be considered. Note here that aspirin with dipyridamole capsules should not be administered via nasogastric tube. The use of combined aspirin and clopidogrel in the first month after a non-disabling stroke or transient ischemic attack for patients in atrial fibrillation without contraindications to anticoagulation, oral anticoagulants such as apixaban, dabigatran, rivaroxaban or warfarin should be used at a dose that is adequate to maintain the international normalized ratio in the range of 2 to 3.